So I'm Ben. I'm one of the surgical registrars currently working at the Evelina Hospital, and I've been asked to talk today about stabilisation and transfer of the surgically unwell patient. Um, so first thing to say that according to a report by the Paediatric Forum of the Royal College of Surgeons of England, um, they suggested that trauma and minor surgical problems account for approximately 85% of childhood A&E attendance. Now, that number does seem a little high to me when you take into account neurological, cardiovascular, and in particular respiratory conditions like asthma. But nonetheless, the message is that surgical pathology will make up a big proportion of your workload if you work in A&E or primary care settings. So there'll be a whole host of different conditions that may be presenting to your institution that require specialist surgical intervention, and it's obviously beyond the scope and time allowed for discussion of the nuances of each of those today, but we can discuss any questions that you might have about particular pathologies at the end if need be. So we'll talk about stabilization of surgical patients in general. So what actually is stabilization? What do we mean by stabilization? Well, stabilization is a process whereby we help prevent a sick or injured person from having their clinical condition deteriorate further before they can be treated in depth at a specialist facility. And in our case, it's a surgical facility. So the assumption here is that we're picking up from where Sophia left off, i.e., that you've already recognized and assessed an unwell child and made your primary differential that this is a child that's suffering with a surgical pathology. So many patients will end up being transferred across to us for specialist opinion. And they'll be so well that they can make their way across on their own. They can come across in their mum and dad's car, or they can make their own way across. But in a proportion of patients, some of them will be so unwell that if they leave your hospital without you intervening first, i.e., stabilizing them, they could either die before transfer or on their way over. So we're at this point here. So you've sought advice from or referred to the paediatric surgery team and liaised with either an ambulance service or a retrieval service in those that are not well enough to come across on their own, patients such as testicular torsions, for example. And we are now in a position where we want to make sure that the patient is stabilized and ready for either transfer or local surgical input. So it's worth noting that it's the responsibility of the referring hospital to initiate resuscitation and stabilization prior to arrival of an ambulance or retrieval team. It's been found that time spent undertaking intensive care interventions early in the course of a patient's illness at the local hospital doesn't worsen outcome. And this is really important because, once upon a time we had this kind of scoop and run model whereby patients would be identified as needing specialist input. They'd be picked up and taken to the local hospital as quickly as possible without stabilization beforehand. And so the message here is that this old-fashioned model is not necessary unless there's specific life-saving therapy that can only be provided at the tertiary centre or the receiving hospital. Otherwise, stabilisation is absolutely vital prior to any consideration of transfer to a tertiary centre. So our stabilisation of a surgical patient is the same for resuscitation of any patient. We follow the ABCD approach: airways, breathing, circulation, disability, exposure, or everything else. And of course, we must never forget glucose. So if we start off with airway, okay. So the airway must be patent and uncompromised prior to undertaking transfer of a critically ill child. As I said, many of our patients will come across to us with the ability to maintain their own airway, patients such as appendicitis generally, testicular torsion, those kind of things. But it's vital that we are certain at the referring centre that they are able to maintain their own airway. Now, this may mean that it's a necessity to utilize endotracheal intubation, and this is normally something that's done by a senior clinician at the local hospital, and should generally, if we're considering endotracheal intubation, this should be attempted prior to arrival of the retrieval team. We shouldn't be waiting for them to arrive for this to be commenced. The other thing to consider is not all patients who are who require require intubation at the point of presentation to the local hospital. Some of them will suddenly deteriorate on their way over, and so it's important to recognise those patients who may require intubation further on down the line. Are they going to deteriorate further down the line? Are they going to be able to maintain their airway? And in those patients, it's important to consider their course from your hospital to ours, and therefore whether or not they're going to need endotracheal intubation. Now, there's various methods that can be used, and it's normally dependent on the indications themselves. The method of intubation is generally favors a modified rapid sequence induction. That's generally the appropriate method, unless there's upper airway obstruction, in which case a gas induction is often preferred. And it's very important noting that you're obviously referring to a surgical team, but one of our surgical co-specialties is the ENT team, and they're probably the most important team to involve in terms of difficult intubation. So if we have a child for whatever reason, for a burn, an inhaled foreign body that is likely to have a very difficult intubation, early involvement of the ENT team, letting them know as soon as possible, can be vitally important. We need to make sure that end tidal carbon dioxide monitoring is available, and this should be prepared in advance and monitored continuously during stabilization and transfer of any patient to us. And at the Evelina in London, we're a cardiac centre, so we get a fair few patients with cardiac pathology, and therefore peri-induction cardiovascular instability should always be considered, especially in children with congenital cardiac disease or shock. And as I said, we see quite a lot of patients with congenital cardiac disease. And the most important initial management in any patient with cardiovascular instability is going to be fluid resuscitation. So we need to make sure that we're giving adequate fluid boluses if need be, and adequate maintenance fluids as well. And in some cases, inotropes may be required. So peripheral dopamine infusion may be necessary, and at the very least should be available, or prepared for transfer. Some patients, in particular in neonates, they may require an opioid-only technique for sedating them. So, for example, the use of fentanyl, and this is particularly important in the neonate with cardiac instability. Many patients will require a cuffed endotracheal tube, and this is especially important if a patient is likely to require long-term ventilation. So there's numerous formulas that can be used for sizing a cuffed DTT in children, and some will depend on the manufacturer, but a commonly used formula is this one here. So for any child over the age of 2, you can use age divided by 4 plus 3.5, and that's a good way of predicting what size cuffed tube should be used for endotracheal intubation. In neonates, they generally require a tube with an internal diameter of between 3 and 3.5 millimeters. So fixation of the endotracheal tube is essential, in particular to transport, and this is particularly important in babies and infants who have very short tracheas. And in these children, small changes in head position, especially when they're wobbling about in an ambulance, can either result in the endotracheal tube coming out entirely, so being extubated, or can come out slightly and then go back down the wrong way, so you end up just intubating a bronchus rather than the trachea itself. The position of the ETT should be verified on a chest X-ray, and we've got an example of that here. So this is a well-positioned endotracheal tube, with the tip lying at the level of the second thoracic vertebra. And if possible, these images, when they've been put in, should always be transferred across to the referring centre. So next we have breathing. And we need to make sure that this is going to be self-maintained as well. So can they maintain their airway, but can they also maintain their own breathing? And it's important to consider here pain relief. So we get a lot of patients who on the ward have difficulties with their breathing because of intense abdominal pain, in particular patients such as those with appendicitis or peritonitis, intra-abdominal collections. They splint themselves by not wanting to breathe adequately because breathing induces pain, and therefore they end up with infections, and some of them end up with quite significant pneumonias because of that. So it's very important to make sure that pain relief is given not just as a kindness, but to aid in ventilation as well. Um, are these patients who are in shock? Are they in septic shock, for example? Are they in hemodynamic shock? Are they in are they patients who might have capillary leak? Have they got pulmonary edema? So these are all things to consider in terms of breathing. Um, Once they're intubated, ventilation should be established on either a transport ventilator or via alternative ventilation source, such as those from the NICU unit from SCBU or PICU. And I've highlighted some difficulties with ventilation that are typically encountered here. So a good approach to remembering the difficulties that you might encounter with ventilation is by using the mnemonic DOPES. So D standing for displacement of the tube, O standing for obstruction. That's particularly important in children with thick viscous secretions or vomiting. Have they developed a pneumothorax? Are there issues with the equipment themselves? So, for example, is there kinking in the tube? Has the ventilator failed? Is there sufficient battery life on them, for example? And finally, stomach and sedation. So, as I said, if a patient is splinting their diaphragm, they're not going to be able to breathe properly. And one of the things that we can sometimes see, particularly in patients with, for example, esophageal atresia, is if they've got air being pumped into their stomach, or for whatever reason they're not able to breathe properly because their stomach has been inflated and it's splinting the diaphragm, then it's going to affect their ventilation. They're not going to be able to support themselves. And in these patients, it's important to, in anyone that's likely splinting their diaphragm because of stomach distension, it's important to place either an NG or OG tube to try and deflate that stomach and take the pressure out of it. And finally, have they got enough sedation on board? Do they need, for example, a bolus of morphine to help them with this? And we all know the importance of blood gases. Blood gases will help us not only at the initial presentation of the patient to get a good idea of their ventilation requirements, but also it's particularly important in the clinically unwell patient to make sure that we're getting routine serial blood gases to make sure that we're looking at the trends of these blood gases. Are these patients who have genuinely been stabilized, or are they someone that looks like they're on a downward trend? Because what we don't want to do is put someone like that into an ambulance and then have them crash halfway across their journey. So serial blood gases are very, very important. Some services, such as our own at the Evelina, are also able to provide ECMO, or extracorporeal membrane oxygenation. So this is a method of removing the blood from the body in patients that aren't able to oxygenate their own blood themselves because of poor ventilation or poor airway. They are put on a machine in which blood is taken out of the body and goes into a machine whereby carbon dioxide is extracted, and the blood is then reoxygenated and returned back to the body. So some centres provide this, and thankfully some centres even provide this in mobile patients, so they can be transferred on ECMO, which can be vitally important and life saving. And as I've said, so it's one of the pathologies that we see relatively frequently, probably seen less in the A&E setting because it's normally a patient that is transferred from a neonatal unit, because it's something that is generally picked up antenatally, but sometimes not. Sometimes it's missed out. Are tracheoesophageal fistulas, or patients with esophageal atresia. So these are patients that have no connection between the top and the bottom ends of their esophagus, and that connection sometimes is aberrant in that it connects to the airway instead. So in these patients, if you imagine if you've got a patient with a quite a wide connection between the airway and the esophagus, if you pump air into these babies, not all of that air is going to make their way to the lungs. Some of it is going to make their way into the stomach. And if you inflate the stomach too much, quite quickly you can splint that diaphragm and you can stop them breathing, and that can become an emergency, a critical emergency. So In patients that we know have tracheoesophageal fistulas, or if they're suspected, then we need to try and support these without intubation wherever possible. If the patient has been intubated or is absolutely necessary to intubate them, then we need to make sure that we're using the lowest pressures possible and treat these patients as a time critical emergency. They need to get to their surgical centre as quickly as possible. And beyond splinting, it's also possible that if you insufflate a baby with a TOF, and you pump too much air into the intestines or the stomach, there's every possibility that you're going to inflate them so much that they just pop. You get a perforation. So in these babies, trying to manage them without intubation is vital, because they can either end up with splinting or perforation of their bowel. So then we have C, circulation. So when you're preparing a patient for transfer to us, or stabilizing them, it's critical to have at least two working IV access points. And this is essential because we know too well that in patients, especially young patients, babies, infants, these can be dislodged, they can be pulled out entirely, they can kink. And a patient who is in shock and requiring fluids is going to need those cannulas for the entirety of their transfer. So at least two working IV access points are essential for transport in case of failure or dislodgement. If venous access is difficult and the child is cardiovascularly compromised, a central venous catheter or an intraosseous needle can be cited. And there's various sites where the intraosseous needles can be placed. So the proximal tibia, distal femur, or the proximal humerus. Fluids, blood products, and inotropes can all be infused via intraosseous routes, but it must be delivered under pressure, so it's worth noting. And in particular, when we're thinking of blood products, we need to think about what type of blood product. So one of those investigations that we want early on, either from the gas or from lab bloods, is a hemoglobin. We get patients who are bleeding for one reason or another. They've been in a trauma. They might have a bleeding Meckel's, they might have had a perforation. There's various reasons why a surgical patient might be bleeding. And in these patients, it's vital that we know what the hemoglobin is, not only for resuscitation, not only for stabilisation, but also for making sure that they're ready for theatre. If this is a child that's going to theatre, we don't want to take them in knowing that we're going to cut them, knowing that we're going to make them bleed when their hemoglobin is already in their boots. So it's vital to make sure that we know what the hemoglobin is and that we manage that appropriately. And in trauma in particular, it's important that these patients are resuscitated with blood. So I've recently come back from the BAPS conference, where we had a trauma training day, and one of the consultants who was teaching us was adamant that resuscitation of a trauma patient, a child with trauma, must have blood. If they're losing blood, they need to have that put back in. It's not good enough just to put saline back in to replace the blood that they've lost. Intraosseous needles need to be well secured, and the site needs to be checked regularly for extravasation. And it's possible at some centres that you can use portable ultrasound devices, ideally with one of those small hockey stick ends on them, to be used to gain either arterial or central venous access. But it's usually the anaesthetists or the intensivists who are able to perform these skills. But ultrasound can be very important in gaining access. And finally, circulatory support must be discussed with the retrieval team, because they need to be kept on board about what's been happening with this patient, how much resuscitation have they needed, and in particular if they need aggressive resuscitation. And this is particularly true in terms of patients who are bleeding, patients with sepsis, for example. So it's important to make sure that the retrieval team and the team that are going to accept the patient are kept abreast of this. As we all know, in children, hypertension is particularly important to monitor, because it can be a very late sign of hypovolemia. So children who have got shock or blood loss can often maintain their blood pressure for much longer than adults can. Adults generally, when they're becoming shocked, will have a slow downward trend in their blood pressure. Children don't. They maintain it very well until they become too unwell to maintain it anymore, in which case they suddenly fall off a cliff. And the blood pressure can suddenly plummet very quickly. So it's incredibly important to keep a very close eye on blood pressure. And if there's any suggestion that this is starting to fall, it needs to be corrected rapidly. Um, and inotropes should really be prepared in advance of any transfer. And if inotrope transfusion is already in progress, then a second drug such as adrenaline should be ready and prepared, and ready to be put up and given to the patient as necessary. Now we don't always advise urinary catheter insertion. The native the urethra is a very, very delicate structure, and if it's never been instrumented, then it should remain that way. We don't like to put catheters in, excuse the pun, willy-nilly in children. However, there are instances where it is needed, and a patient who's shocked and is likely to require ongoing fluid resuscitation and monitoring of the fluids that they've got going in and coming out, then a urinary catheter can be very important, because we need to make sure that they're passing urine. If they're not passing urine, they're clearly shocked and they need more fluids, or they need better resuscitation. So there are times when placing a urinary catheter to monitor urine output hourly can be very, very important. There are also an increasing number of DGH pediatricians and neonatologists in particular that are able to perform bedside echocardiography, and this can be invaluable in diagnosing abnormal cardiac morphology. And this is particularly important, as I said, for centres such as ours who accept cardiac patients, because we need to make sure that if we're going to take these patients to theatre, we're prepared for that. We have the right type of anaesthetist on board. We have a cardiac anaesthetist ready to take the patient. And also it can help us with our own surgical planning. TOFs, for example, if we've got a better idea of cardiac and great vessel anatomy, then it can affect our planning surgically of these patients. And so just to reiterate this point, the most important thing with fluid resuscitation is knowing that they've had enough. Some patients will come across to us, they'll arrive at our centre mottled, cold, quite obviously shut down, and the reason being is that the referring team have thought they've done enough because they've put up a bag of maintenance fluids. They've recognised that patient needs fluids, but all they've given is maintenance. They haven't recognised that this patient is already now well behind in the amount of fluid they should have. They've been vomiting for the last 24 hours, or they've got various other insensible losses. They're already shut down, and so these require at the least a bolus with maintenance fluids. Sometimes they might require mil for mil replacement if they've got a stoma, for example, and they've got a very high output, and they therefore need whatever's coming out to go back in. So some of these patients will need 10, 20, if not more, mil per kilos of fluid resuscitation as boluses on top of their maintenance fluids. Maintenance fluids is the bare minimum, but will not help out these patients who are in shock and requiring transfer to a surgical unit. And then we have disability. So if the child is intubated prior to transfer to us, then they must be adequately sedated and paralyzed with transport. And we use for sedation morphine, midazolam, for example. They must have sufficient analgesia, and regular GCS monitoring must be performed. So as I said, it's not enough just to do a one-off of any of these investigations, to do a one-off BM, a one-off blood gas, one-off GCS. We need to be looking at trends. We need to be looking at whether or not these patients are going to maintain these parameters throughout their transfer. Is a patient with a normal GCS now likely to have a normal GCS halfway through their transfer to us? And if they've got a reducing GCS, is it going to be reduced so much that they're no longer able to maintain their airway? And then finally, everything else, or exposure. and also don't ever forget glucose. So temperature control. Temperature control is very important for transfer and stabilization of the sick child. Um, and we must always aim for normothermia unless, for any reason, cooling's indicated. For example, in the patient with HIE, the neonate that's been transferred across for specialist input because of HIE, they may require cooling. Everyone else generally should have normothermia. Um, and this needs to be maintained throughout the entirety of your assessment of the child and throughout transfer. And it's quite easy to forget just simple measures when you're assessing a patient, you're discussing with seniors. Simple measures such as simply putting a blanket over their legs, making sure they're wrapped up well. Um, Infants, in particular, can be placed on specially designed warming devices, such as what we use in theatre, bear huggers, and various other mats that can help warm them. In addition to the use of hats and, as I said, simple measures like hats and blankets. But core temperature must be monitored for the duration of the transfer, and this can be done with devices such as rectal probes if need be. And in particular, particularly pertinent to surgical patients, we need to be aware of heat and fluid losses in patients with either burns or ventral abdominal wall defects. So, for example, like we have here, omphalocele or gastroschisis, whereby patients are born with their intestine either wrapped in a peritoneal sac or without a peritoneal sac, but their intestine is born is on the outside of their body, and therefore these patients are um, susceptible to losing heat and losing fluid very rapidly. So in these patients, it's particularly important to make sure that normothermia is maintained, and generally we would advise that if possible, you wrap these children in cling film. So you literally get some cellophane and wrap it around the baby so that any any moisture that is being lost because of the heat loss is maintained within their compartment and able to be reabsorbed so that they're not losing heat and fluid too rapidly. Um, so in infants and younger children, hyperglycemia is a very common finding associated with critical illness, and this is due to the fact that they have a very high metabolic rate. They've also likely, if they've got a surgical pathology and they've been vomiting a lot recently or they've been in lots of pain, they're unlikely to have been able to either eat because they just don't want to, or whatever they have taken in has come out again in the form of vomiting. So they've had poor intake, and therefore their glucose can dip because of that. And also their illness itself can create a higher glucose demand. So it may be that they have been eating, they're just not able to meet their requirements because of the illness themselves, because of the illness itself. So blood glucose levels should be monitored regularly, and infusions of saline and dextrose, either with or without potassium, should be used in most situations to maintain glucose levels. We also need to consider whether maintenance fluids are at the correct rate. So as I said, in most children, we'd give boluses, we'd give maintenance fluids. But in some children, particularly if you've got a patient who has very recently had surgery and is likely to have a lot of edema, sometimes having too much fluid can be dangerous. They can get a capillary edema, they can get pulmonary edema because of that. And so sometimes, and it's worth discussing this with seniors or the team that you're referring to, sometimes maintenance fluid should be brought down a little bit to 2/3. And in particular, in some sick children, it can result in increased ADH secretion. So, fluid management is really quite a complex issue, and is something that should generally be discussed with seniors if there's any concern at all. As I said, in the majority of patients coming into A&E who are shocked, they need maintenance, they need those fluid boluses. Um, and the other thing to be aware of with all of this, so as I said, we've checked glucose, we've checked GCS, we've checked temperature. We need to make sure that these are going to be adequate throughout the transfer. If they're going to be transported to us, are all of these things going to be maintained? What are those trends doing, as I've said before? So we're now at a point of handover, and hopefully by this point you've already spoken to the surgical team, you've spoken to the retrieval team or the ambulance team. But it's important at this point to make sure that all the salient points in the history, the investigations that you've done so far, the management that you've already started are communicated to the retrieval team and the accepting department. And this is not necessarily the surgical team. Most often, when you've referred to the surgical team, you've already gone through most of this already. But what we do sometimes find is that patients will turn up in A&E after a surgeon has accepted the patient, and the A&E team don't really know what's going on. They have to get most of their information either from the ambulance crew or from the note that's sent across. Sometimes the ambulance crew don't necessarily know as much as they'd like if it's been a very quick transfer because of a very unwell patient. Sometimes the transfer letters will literally say accepted by surgical team, thank you. So the transfer of information and documentation can be very poor. So therefore, it's very important that at least one member of the team, when transferring a patient, has a chat with the people who are going to be on the floor accepting the patient when they arrive, which is more often than not the A&E nurses or the A&E doctors. And there's various tools that can be used for this. So some centres will use the CATS tool, some use the STOPP tool, and it's basically just a very quick and easy pro forma with a list of things that need to be handed over to the people who are accepting the patient and going to be instigating their initial phases of care. All this information needs to be clearly documented in a transfer letter, and this should be given so that they can assist the people accepting the patient. You need to remember that when you're referring a patient to a surgical team, it's not going to necessarily be the same person accepting that patient when they arrive, because transfer can take many hours, and the team that was initially referred to might be off duty by that point. So transfer letters, detailed transfer letters with all the relevant investigations, can be vitally important. If the child is potentially infectious or is already colonized with a specific organism such as MRSA, or if they've had profuse vomiting, as is often the case with surgical referrals, then they will require a cubicle, and the receiving department must know this prior to being transferred across so that the preparations can be made. And finally, we need to know, are there any child protection issues? Any known or potential child protection issues must be communicated to all staff involved in the care of a patient. It's every healthcare worker's responsibility to ensure that the correct procedures are followed with any child under potential risk of child protection issues. So, in summary, in stabilizing our patient, we have made our diagnosis, we've sought advice from the local team, referred to the local team, and we've gone through our typical ABCD approach: airways, breathing, circulation, disability, exposure, or everything else, and then DEFG. Don't ever forget glucose. Um, we I hope I've stressed enough how important fluids are and how good IV access is vitally important. They need analgesia, and as I said, this is not just a kindness. This can be imperative to maintaining breathing and airways. And one of the things we sometimes find is that patients are not given analgesia because the referring centre believe that they might somehow mask our findings when the surgeons review them when they come across. That's not the case. If a patient has a proper surgical pathology, such as appendicitis, such as a torsion, you giving them some paracetamol or even some morphine is not going to mask their symptoms. So they need their analgesia. When we're worried about vomiting, when we're worried about splinting of the diaphragm, we need to make sure they've got an NG or an OG tube in place, or a replogal tube, which is a tube that's basically can be put, it's like an NG that can be put on suction to make sure that secretions are removed. And these need to be left on free drainage. We have lots of patients that come across to us with NGs in, but they're spigoted, so they're doing nothing. It's just annoyance to the child, and they're not draining the stomach at all. So we need to remember that if we put an NG tube in, we're putting it in for a reason. They need to be on free drainage. Do they need a catheter? And what local investigations have you done, or interventions have you done that may need to be transferred across? Have you done x-rays? Have they been transferred across? Have you done bloods? Are they in the letter? Have they been handed over to us? As I said earlier, that life-saving interventions need to be done at the referring centre. This shouldn't delay transfer, but they are needed. However, we do sometimes get patients who have only been discussed with us after an ultrasound has been, a patient that is very unwell, is in shock, is suspecting intussusception, and the local team has already done the ultrasound. That's great and it's very helpful, but that patient needs to get across to a surgical centre as quickly as possible. And if an investigation such as an ultrasound, and in particular CT, because we get a lot of patients that come across to us with CTs, and that should very, very rarely ever happen in a child that they've had a CT before being discussed. These are potentially things that can delay transfer. Um, so, so one of the other things to consider is we often get referrals from other centres where we want a surgical opinion, and that's completely understandable. We're paediatric surgeons, you're paediatricians, and you're asking for surgical advice. But many of the pathologies we end up treating, such as appendicitis, such as torsions, are things that also the local surgeons in your hospital do treat. And so sometimes we'll get calls about, for example, a 15-year-old boy with a query appendicitis or a 16-year-old with a query torsion. These are things that, in order to save time for the patient, could potentially be discussed with your own team. So it's very important to make sure that you've got them on board first. There may be reasons why they can't see the patient, why they don't want to discuss the patient. That's often the case if they're complex or if they're very young. But we don't want to waste time transferring, particularly something like a torted testicle, across to another centre when there are local specialists that can deal with these pathologies. So just a few notes very quickly on the transfer itself. So these are some things to consider in terms of the actual transfer of the child. Is the transport absolutely necessary? Can images alone be sent across for a specialist opinion? Surgeons don't typically like to comment on X-rays alone without reviewing a patient clinically, without actually examining the patient. But is it something that could potentially save a transfer if an X-ray could be looked at either by a surgeon or by a local radiologist that is able to give an expert opinion? Could it be that the surgeon is able to travel to the patient? This sounds odd, but it's actually the case that many of the DGHs that refer to us do have surgical consultants that will come and visit their department once or twice a week for clinics or surgical lists. And it may be that some of these patients are well enough actually that they don't need transfer overnight. They can wait till the following day, because it may be that a consultant is on their way over the following day to do a clinic there anyway. So that's something worth considering. Again, it's always worth discussing with the team that you're referring to, because otherwise you wouldn't be privy to that information anyway. But it may be that some of these patients don't actually require transport. Is the transport time critical? Is this someone that's going to need one of those scoop and run type things? This is a patient who's going to perish if they don't have management that only a surgical centre can provide. Or is this something that needs to be more planned, and the patient needs stabilisation before any consideration of transfer? Is local surgery indicated? Is this something that may be a complex surgical pathology, but is it a trauma, or is it something that a local surgical team can perform damage control, life-saving surgery before transfer across to a specialist centre where the more definitive surgery can be performed? What is your team for transport? Do you have a trained retrieval team, or do you have an experienced local team? So it's worth working out what kind of team you've got available for the transport of the patient. Communication's vital in updating not only the team referring the patient, but also we need to remember the parents as well. It's very important to keep them in the loop to make sure that they know exactly what's going on with their child. I've touched on this previously, but it's important to keep all patients who are going to be caring for this all practitioners who are going to be caring for this patient in the loop of any clinical change. So what we don't want is to get a story on referral of a patient that is relatively well but clearly needs to come across. Things change, and the accepting team are not made aware of that, and then the patient that we get the other end is in a very different clinical condition than we were expecting. We're just not prepared, either mentally or physically, with equipment, with with readiness for surgery, for example. One thing to note just very quickly is that surgeons will often have to call the referring team sometimes quite late into the night because of a referral that may have been made hours and hours before. And we know that transfer takes a long time, and therefore we wait a long time. But we may be waiting up till 2 in the morning sometimes to receive a patient, anticipating that they may need surgery, that we're going to go down and have to see them and prepare them for theatre. And sometimes we'll suddenly think, what's going on? Why has this patient not turned up yet? And this has happened to me several times where I'll call the referring team, and they'll say, oh, the patient didn't need to come in the end, or they ended up going to their local centre, or there's been some massive change in plan that has meant that the patient is no longer coming to us, and we weren't aware of it at all. And that can be a little bit mean in terms of the fact that we need to sleep at some point, but also we have to triage our surgical patients. We need to plan theatre based around who we think needs it the most. And if we think we've got a patient who's on their way in, a baby that's going to need a laparotomy within the next hour, for example, and we've got other patients waiting for theatre, it may be that we're holding them back whilst we're waiting for this other patient to arrive. And so to find out the patient is no longer coming to us can be mean to the surgeon, but can also be detrimental to the other patients waiting. Finally, the parents. So as I said, it's important to make sure that they're kept in the loop in the kind of chaos of resus and stabilisation and transfer, that the parents can be forgotten about. And it's important to make sure that they have all the details of where the child's going. I often get patients that will come to us with parents that say they had no idea where they were going. They just followed the ambulance, or they were in the back of the ambulance. They didn't know they were coming to the Evelina. They don't really feel like they're kind of up to speed with what's going on with their child. So it's important to keep them in the loop. And importantly for surgeons, it's important that we have some line of communication with the parents, because ultimately surgeons operate, and if we're going to operate, we need to gain consent from these parents. And so it can be very difficult if a patient comes across to us within an hour, 2 hours later the parent is nowhere to be found, is not accessible on the phone. So it's important that we have a line of communication with parents so that we can take consent, and if need be, we get phone numbers, we do that over the phone, but we need to do that before we can consider taking them to theatre. And finally, in terms of the ambulance itself, in terms of transferring patients across, safety is paramount for not only the patient but for the doctors and the nurses involved. So I've known of at least one neonatal colleague that had quite a significant crush injury because heavy equipment wasn't rigged down properly in the ambulance, and as the ambulance went around the corner, it came across the room, and she suffered a head injury because of that. So it's important that the patient, that the doctors, the nurses, and the equipment itself are all rigged down and secured tightly when patients are being transferred across to us. And that's pretty much it.
Thank you so much, Ben. That was a really great systematic kind of run through of how to stabilise and then transfer a patient with a surgical problem. So thank you.
Thank you.
Great. I just wanted to draw your attention to the STOPP tool, actually, if that's okay. So that's something that as a network we have supported. So it's the safe transfer of the paediatric patient, and it's a really good systematic tool to assess a patient going through those steps that Ben's just described. And in the last version, there was a real kind of emphasis put on the surgical patient, particularly resuscitation, fluid resuscitation, and going back to reassess after those interventions and after pain control had been initiated. So this is what it looks like. I'm sure many of you have seen it and are using it. So this is the important bit, the patient risk assessment prior to transfer. So as you can see, it takes that systematic approach. There's 2 columns here for your first assessment, and then a reassessment after those interventions. And it might be that you need to go on and do 3rd and 4th assessments. I'm sure Ben will back that up. There's space here to put some information about the patients and how much has been needed. This bit here about fluid balances and checking if the patient remains shocked or needs ongoing resuscitation or is actively bleeding was down in this surgical section, but it was felt to be missed in some septic cases. So it's back up under C, which you can't argue with, can you? So once those assessments and interventions and reassessments have been done, you go on to do an assessment of the type of transfer the child needs. So it might be that they go on to need a level 3 STRS transfer, and even the level 1 and 2, it does suggest that in discussion with the consultant that STRS transfers, or at least discussions with the retrieval team, are had. So it initiates those discussions. But I think this tool really comes into its own in those borderline children that perhaps aren't the critical care transfers, but have that potential to change over time, like Ben described. And it helps you make decisions around who should transfer the child, with space to write down plans and discussions with consultants.